Dr. Jonathan is here, right? So we next call upon Dr. Jonathan Chavan. His topic is double trouble endogenous endophthalmitis in a chronic one-eyed VKH patient.
Good afternoon, everyone. I'll be presenting on a rare case of endogenous endophthalmitis in a chronic one-eyed VKH patient. So both VKH and endogenous endophthalmitis can cause dreaded ophthalmic complications. VKH needs to be treated with aggressive immunosuppression, and endogenous endophthalmitis needs prompt treatment with systemic antibiotics and to do a co-vitrectomy. So 10 years ago, a 47-year-old female first presented to our clinic with right eye decreased vision since 4 years and left eye decreased vision since 2 months. In both eyes, there was associated intermittent redness. Positive history was she gave history of hearing loss, and negative history there was no ocular trauma. We did a B scan which showed thickening of the RCS complex. So our initial diagnosis was right eye prethysis bulbi and left eye was VKH. We started topical and oral steroids, and because VKH is an absolute indication for immunosuppressants, we started methotrexate. Following treatment, her vision improved from 636 to 6/6. Inflammation was well controlled, and after cataract surgery, her vision also was 6/6. Due to multiple recurrent episodes with methotrexate, we decided to switch to MMF, and for almost 10 years she had inactive uveitis. Then suddenly she presented to us with a drop in vision from 6/6 to 5/60. On ocular examination, there was active inflammation with 2+ cells and flare, and on fundus examination there were 3+ cells with a vitreous haze of 3+. When we did the B scan this time, there were dot echoes present with a normal RCS complex and no evidence of retinal or choroidal detachment. So we were wondering what this could be. Could it be VKH or is it something else now? So we suspected endogenous endophthalmitis because of the sudden dense vitritis. We did a urine culture which was positive for Streptococcus viridans, and ultrasound abdomen was suggestive of pyelonephritis. So we immediately stopped immunosuppressants. We started topical antibiotics. With the help of a urologist, we started oral antibiotics. Then we did a co-vitrectomy and injected intravitreal vancomycin, ceftazidime and voriconazole. Following treatment, her vision improved to 6/6. So we both know that endogenous endophthalmitis and VKH can cause a poor visual prognosis. Unfortunately, the immunosuppressants used for VKH can predispose to endogenous endophthalmitis. So the clue to endogenous endophthalmitis in our case was the sudden onset of severe vitritis, which we do not usually see in chronic recurrent VKH. So therefore, with this alertness, we were able to save the only seeing eye of a one-eyed patient and helped her regain 6/6. So we like to conclude that it's always important to pay attention to even the most subtle changes in clinical findings in every case of uveitis that comes to our clinic. Thank you.
Especially if they are on immunosuppressants
Yes,
for a long term.
So it's a very nice presentation. I'm wondering why this entire thing happened. See, the patient has to be reasonably immunosuppressed
Yes, sir.
for him to get infection at 3 different sites.
Yes.
I would be really interested in knowing what the total leukocyte count is like. Was the patient into something like a bone marrow suppression or
No, sir. She used to come for a regular follow-up with us, sir. Every 2 to 3 months, she comes for checkup. Her leukocyte
and
count was
and
normal.
then you're really scaring me if you're saying
Yes,
that.
sir. Yes, sir.
Okay.
So what you're saying is you couldn't pick up the TLC drop, the bone marrow suppression earlier.
Yes, sir, ma'am.
Right. Okay. Thank you.
Okay.